Okay, so today we're going deep on something that's pretty common in cardiology, but can be pretty tricky to manage.
Yeah.
And it's a case where we see two conditions kind of colliding in a way.
Uh-huh.
So we've got some detailed cardiology notes here, and they're all about a patient who has both mitral regurgitation and atrial fibrillation,
Right.
two big players in heart health.
Absolutely.
Now, our listeners are sharp, they're here to learn, and they want to get to the heart of the matter quickly.
Yeah.
So we're going to extract the key insights from these notes quickly and thoroughly as always.
Absolutely.
Our mission today is to understand how these two conditions, mitral regurgitation and atrial fibrillation, are identified in the first place.
Right.
Then we want to see how they might be related,
Okay.
because it's not just that they happen to be present at the same time,
Yeah,
right?
exactly.
And then finally, we want to nail down how to manage these conditions,
Right.
especially when they're happening together.
Yeah, that's the real challenge.
So these notes, they basically give us a front row seat to the diagnostic process
Uh-huh.
and to the management considerations when you have these two conditions at the same time.
Right.
So let's dive in.
Absolutely.
Let's start with the initial presentation.
Okay.
So the assessment right away points to atrial fibrillation, AND mitral regurgitation, right?
Yeah.
What were those early clues that made the clinicians even suspect that both of these conditions were present?
Well, I think the physical exam findings are really key here.
Okay.
They talk about an irregular pulse,
Right.
and that's like a classic sign
Yeah.
of atrial fibrillation.
Right.
That's where the upper chambers of the heart, they're just kind of going haywire electrically.
Right. Total chaos.
Exactly. And then when you get to the description of the heart murmur,
Okay.
that's where things start pointing towards mitral regurgitation.
Got it.
So they noted this pansystolic murmur,
Okay.
which means that it's lasting throughout the entire contraction phase of the heart. That's the systole part, yeah.
Right.
And it was loudest at the apex.
Okay.
That's the tip of the heart, right?
Mm-hmm.
But here's the interesting thing. It radiated to the axilla,
Axilla.
the armpit area,
Right.
when the patient was lying on their left side.
Interesting.
And that pattern of radiation is actually very characteristic of mitral regurgitation.
Okay.
And that's where blood is leaking backward from the left ventricle into the left atrium.
Okay, so it's like a backflow.
Exactly, a backflow.
And they also mentioned that the second heart sound was inaudible at the apex.
Right, which also further supports that idea of mitral regurgitation.
Okay, so those physical findings, they really start to paint a pretty clear picture, even at that initial stage.
Absolutely.
Now, the notes then go on to detail how they further evaluated the mitral regurgitation.
Oh.
What are some of the essential steps to really get a grasp on what's happening with that valve?
Well, you have to be very thorough to figure out what's causing it
Right.
and how severe it is. So the first thing, as you pointed out, is a really detailed patient history.
Right.
And here we're particularly interested in any history of childhood infections,
Okay.
especially things like rheumatic fever,
Yeah.
because, rheumatic fever can damage the heart valves
Yeah.
and cause problems down the line.
Later in life.
Exactly.
So that's a long-term kind of thing to consider.
Right. But we also need to think about anything recent that might be going on.
Okay.
So recent illnesses, recent procedures,
Uh-huh.
we have to rule out things like infective endocarditis.
Okay.
That's an infection of the heart valves.
So it's kind of looking at both ends of the spectrum.
Exactly.
Long-term history and then any potential acute issues.
Absolutely.
Now, beyond the patient's history, what other investigations are important here?
Well, blood tests definitely play a role.
Okay.
And you'll notice that they mentioned 3 sets of blood cultures.
Right.
That's very specifically to rule out that infective endocarditis.
Okay. Makes sense.
An electrocardiogram, or EKG, is also done. Right. And that's primarily going to help diagnose the atrial fibrillation.
Okay.
But sometimes it can give you some clues
Uh-huh.
about structural heart problems.
Interesting.
However, the real workhorse
Oh.
for evaluating mitral regurgitation is the echocardiogram,
Right, the echo.
that ultrasound of the heart, yeah.
So what specifically would the clinicians be looking for on that echo in this case?
Well, the great thing about the echo is that it lets us actually see the mitral valve
Yeah.
and see how the blood is flowing through it.
Uh-huh.
So using something called Doppler flow,
Okay.
we can actually see if blood is leaking backward.
Uh-huh.
And that's the hallmark of mitral regurgitation.
Makes sense.
We would also measure the size of the left atrium,
Okay.
because if there's chronic mitral regurgitation,
Right.
the left atrium often gets bigger
Okay.
because it has to handle that extra volume of blood.
Right. It's got to work harder.
Exactly. And the notes mention looking at the angle of what we call the regurgitant jet. Yeah, that's the stream of blood that's leaking back.
Okay.
And that can sometimes tell us if there's mitral valve prolapse.
Right.
Which is a common cause of primary mitral regurgitation.
So mitral valve prolapse.
Yeah, think of it as one of the leaflets of the valve kind of bulging back into the atrium when the heart contracts.
It's like a door that doesn't quite shut all the way.
That's a great analogy, yeah.
Okay, so they're really building this detailed picture of the mitral valve,
Exactly.
both how it looks and how it's functioning.
Right.
Now, the notes also emphasize that the atrial fibrillation needs to be further investigated.
Mm-hmm.
What's the general approach when we're trying to figure out what's going on with AFib?
So there are three main things we focus on.
Okay.
First, we try to figure out what's causing it or what might be triggering it.
Okay.
Could be a lot of things.
Yeah.
High blood pressure, coronary artery disease, thyroid problems, even too much alcohol.
So a pretty broad range of possibilities.
Absolutely. Second, we need to see if the patient is actually having any symptoms.
Right, because sometimes they're not.
Sometimes they don't, and the symptoms can vary quite a bit.
Okay.
Palpitations, shortness of breath,
Right.
feeling tired, feeling dizzy.
A lot of different ways that can manifest.
It really can. And then third, based on the cause and the symptoms,
Right.
we start thinking about how to manage it.
Okay, and when it comes to managing atrial fibrillation, the notes outline two main strategies. Rate control
Yeah.
and rhythm control.
Okay.
So can you break down what the difference is between those two approaches?
Sure. So rate control is all about slowing down the heart rate.
Okay.
Get it into a more normal range,
Uh-huh.
even if the rhythm is still irregular.
Right.
Just by controlling how fast the heart is beating, you can really help with symptoms
Okay.
and prevent complications.
Makes sense.
Medications like beta blockers
Right.
and digoxin are often used for that.
Okay, and what about rhythm control?
Rhythm control is more about restoring,
And maintaining a normal, regular rhythm.
get it back on track.
Exactly, what we call sinus rhythm.
Sinus rhythm, okay.
And that can sometimes be done with medications.
Right.
Like flecainide.
Flecainide.
But it's important to note, and I'm sure the notes emphasize this,
Uh-huh.
that flecainide should really only be used in patients
Okay.
who don't have structural heart disease.
Right.
Because there can be some risks.
Okay, so that's a really important point to remember.
Absolutely.
Now, the other method mentioned for rhythm control is mechanical cardioversion.
Right.
So what does that involve?
So mechanical cardioversion,
Okay.
sometimes called DC cardioversion,
Uh-huh.
it involves delivering a controlled electrical shock to the heart.
Okay.
It's kind of like hitting the reset button
Interesting.
on the heart's electrical activity.
Okay.
Hopefully that'll restore normal rhythm.
And if they're going to do a cardioversion,
Right.
it's absolutely crucial that the patient is on adequate anticoagulation beforehand.
Yeah. Why is that so important?
Because it helps to minimize the risk of any blood clots
Okay.
that might be present in the atria
Uh-huh.
from getting dislodged
Right.
and potentially causing a stroke.
Okay. So that's a big concern.
It is.
You mentioned the risk of blood clots earlier.
Right.
The notes specifically talk about the risk of thrombus formation
Uh-huh.
in the atria
Right.
in the setting of atrial fibrillation.
Yeah.
So why is that such a significant concern?
So when the atria are fibrillating,
Okay.
they're not really squeezing effectively.
Right.
They're just kind of quivering,
Mm-hmm.
which means the blood inside isn't moving as well as it should.
Right.
And when blood sits still, it's more likely to clot.
Okay.
So you can get these thrombi forming,
Mm-hmm.
and if a clot breaks free,
Right.
it can travel through the bloodstream
Uh-huh.
and get stuck somewhere else,
Okay.
blocking blood flow.
And that's an embolism.
Exactly. That's an embolism.
Right.
And if it goes to the brain,
Uh-huh.
that's a stroke.
That's a big problem.
It is a very serious complication.
So preventing these clots is a major focus when we're managing atrial fibrillation.
Absolutely.
And that brings us to the CAUDS VASCI score.
Okay.
Can you walk us through what this is and how it helps in assessing that risk?
So the CAUDS VASCI score
Yeah.
is basically a tool that helps us estimate the risk of a patient with AFib having a thromboembolic event like a stroke.
Okay.
And it takes into account a lot of different risk factors.
Right.
And assigns points to each one.
Uh-huh.
So the acronym itself actually tells you the factors.
Okay, tell me.
So C stands for congestive heart failure.
Okay.
H is for hypertension.
Right, high blood pressure.
Exactly. A2 is for age.
Okay.
Now, if the patient is over 75, they get 2 points.
Yeah.
If they're 65 to 74, they get 1 point.
Okay.
D is for diabetes.
Diabetes, got it.
S2 is for a prior stroke or a TIA.
Right.
That gets 2 points.
Okay.
V is for vascular disease,
Oh, yeah.
like a prior heart attack or peripheral artery disease.
which gets 1 point.
Okay.
And CC is for sex category.
Okay.
If the patient is female, they get 1 point.
1 point. Got it.
So you add up the points based on the patient's specific health history,
Right.
and it gives you this overall score.
And what did those scores tell us?
Basically, the higher the CH-Euro-VASC score,
Okay.
the greater the estimated risk
Yeah.
of having a thromboembolic event.
Okay, so a higher score equals higher risk.
Pretty much, yeah.
And the notes mention that if the score is greater than 1,
Uh-huh.
they usually recommend anticoagulation
Right,
to try to lower that risk.
exactly.
Okay, so what are some of the options for anticoagulation in these situations?
So the guidelines typically recommend considering either DOACs.
Okay, DOACs.
Yeah, those are the direct oral anticoagulants.
Uh-huh.
The notes list some examples like apixaban, rivaroxaban, dabigatran, and edoxaban.
Right. And then the other option is warfarin.
Exactly. Warfarin is the other main option.
Yeah.
Now, DOACs, they're generally considered a little bit easier to manage, right?
Yeah, they don't require the same frequent blood monitoring that warfarin does.
Right, which can be a real advantage for some patients.
It is for many patients.
Now, the choice between a DOAC and warfarin can depend on a bunch of things, right?
It can, yeah.
It can depend on the underlying cause of the atrial fibrillation,
Uh-huh.
any other medical conditions they might have,
Right.
patient preference as well,
Uh-huh.
after you discuss the risks and benefits.
Absolutely. Shared decision-making is key.
And the notes mention that the specific reason for the atrial fibrillation
Okay.
can sometimes influence the choice as well.
It can, yeah.
Okay, so that's a really good rundown of how to manage the atrial fibrillation.
Uh-huh.
But now let's pivot back to the mitral regurgitation
Okay.
and kind of consider it in a broader context.
Right.
Because the notes mention that it's actually the second most common reason
Wow.
for needing heart valve surgery in Europe.
That's significant.
It really is. It highlights how common it is. Now, the notes were really helpful in distinguishing between primary and secondary mitral regurgitation.
Okay.
So in primary MR, the problem is directly with the mitral valve itself.
Uh-huh.
So the leaflets, the chordae tendineae, right?
Which are those little cords that support the leaflets or the annulus, the ring around the valve?
Okay, so it's a problem with the actual structure of the valve itself.
Exactly.
And what are some of the most frequent causes of primary MR?
Well, degenerative changes are a big one.
Okay.
Things like mitral valve prolapse
Huh.
or a flail leaflet where part of the valve just doesn't close properly.
Right, it's like a damaged door.
Exactly.
Now, secondary mitral regurgitation is a little bit different.
It is, yeah.
So how is that different in its origin?
So in secondary MR, or what we sometimes call functional MR,
Okay.
the mitral valve itself is actually structurally normal.
Interesting.
The leak happens because of changes in the left ventricle,
Okay.
that main pumping chamber.
Uh-huh.
So this is often seen in people who've had a heart attack
Okay.
or have a weakened and enlarged heart,
Right.
what we call dilated or ischemic cardiomyopathies.
Okay, so the ventricle itself is not working properly.
Right, and because of that, the ventricle's changes kind of pull on the mitral valve,
Uh-huh.
preventing it from closing tightly.
Okay, so it's an indirect problem with the valve.
Yeah, it's not the valve's fault.
It's the ventricle's fault.
Exactly, but here's another interesting thing the notes point out.
Okay.
That annulus, that ring around the valve,
Uh-huh.
it can become dilated because of chronic atrial fibrillation
Oh, wow.
and enlargement of the left atrium.
So the AFib is actually contributing
It can, yeah.
to the structural problem of the MR.
Exactly. So you see, it's not just about a faulty valve or a misfiring rhythm.
Yeah.
Sometimes one can actually make the other worse.
That's fascinating.
It is. It really shows how interconnected everything is.
So how do clinicians figure out how severe the mitral regurgitation is?
Okay.
And then how do they decide what the best way to manage it is?
Well, echocardiography is essential here.
The echo again.
Yeah, the echo is our friend.
Okay.
It lets us see how bad the backflow is,
Uh-huh.
but also helps us understand why it's happening.
Well-
What's the underlying mechanism?
Right.
We can also see how well the left ventricle is pumping,
Okay.
measure the left atrium,
Uh-huh.
estimate the pressure in the lungs' blood vessels.
Okay.
All of that gives us a really good sense of how the mitral regurgitation is affecting the heart.
Right. The overall impact.
Exactly. So
Yeah.
usually we start with a transthoracic echocardiogram,
Okay.
which is done through the chest wall.
Right.
But sometimes if the images aren't clear enough,
Huh.
or if we need a super detailed look at the valve
Okay.
to see if it can even be repaired,
Right.
We do a transesophageal echocardiogram, a T,
T?
and that involves passing a small probe down the esophagus
Okay.
to get a better view.
From inside?
Kind of, yeah, from behind the heart.
Okay.
Gives us a different angle.
Okay, so at what point does surgery become an option for mitral regurgitation?
So for severe chronic primary mitral regurgitation,
Okay.
surgery is usually indicated if the patient has symptoms.
Right.
Things like shortness of breath, fatigue.
Makes sense.
But even in patients who don't have a lot of symptoms,
Okay.
there are certain signs that suggest they might have a worse outcome if they don't have surgery.
Okay, like what?
Well, things like a low left ventricular ejection fraction.
Okay.
That's a measure of how well the heart is pumping.
Right.
If it's below 60%.
Okay.
Or a large left ventricular end systolic dimension.
Okay.
That's the size of the left ventricle at the end of contraction.
Right.
If it's greater than 45 millimeters.
Yeah.
The presence of atrial fibrillation
Right.
or high pressure in the pulmonary artery.
Got it. So those are some specific markers that they would look at.
Exactly.
And the notes also talk about the type of surgery that's preferred.
Right. So generally speaking, repairing the mitral valve is preferred over replacing it,
Okay.
if it's possible.
Why is that?
Repair usually leads to better long-term outcomes.
Okay, makes sense.
But in patients who don't have symptoms
Right.
and don't have those specific indicators for surgery,
Ah.
often we'll just watch and wait.
Okay, watchful waiting.
Exactly. Monitor them closely.
Mm-hmm.
But surgery can still be considered in certain cases,
Okay.
like in low-risk asymptomatic patients
Uh-huh.
who have a normal size and functioning left ventricle.
Right.
And if the surgeons think they can do a really durable repair,
Okay.
and if the patient has a flailed leaflet
Oh,
or a large left atrium while they're in a normal rhythm.
interesting.
So it's all about carefully weighing the risks and benefits.
Right. It's not a one-size-fits-all approach.
Absolutely not.
Now, what about secondary mitral regurgitation?
Okay.
Is the treatment strategy the same?
It can be a bit different because secondary MR,
Right.
it often means there's more advanced heart disease going on. Uh-huh.
And the prognosis might not be as good.
Okay.
And there's not a lot of evidence to show that surgery in these cases
Right.
consistently helps people live longer.
Okay.
So the main focus in secondary MR is managing the underlying heart failure.
Okay, so treating the root cause
Exactly.
makes sense now, bringing it all back together.
Yeah.
Especially with atrial fibrillation being in the mix as well.
Yeah.
The notes remind us about some important risk assessments and guidelines.
Okay.
So can you just walk us through those one more time?
Sure. So whenever we have a patient with atrial fibrillation,
Okay.
whether or not they have mitral regurgitation,
Right.
we always think about the CH-area-VAS score.
Right.
That helps us assess their risk of stroke and other clots,
Uh-huh.
but we also have to think about their bleeding risk,
Okay.
especially if we're considering anticoagulants.
Right.
And for that, we use the Haspiolis score.
SPL.
Okay. And there are guidelines from the CNISC,
Okay.
the National Institute for Health and Care Excellence.
Right. And they provide a lot of recommendations
Uh-huh.
on when to use rhythm control versus rate control,
Okay.
the AFib.
Right.
They also give a lot of detail on the different anticoagulant options,
Ah.
both warfarin and the DOACs.
Okay.
And the notes make a good point about warfarin.
Okay.
If a patient has really erratic INR levels,
Right.
it can be hard to manage their anticoagulation.
Okay.
So you might need to rethink whether warfarin is the best choice.
Okay. So it really is a holistic view.
It is,
You
yeah.
have to understand both the mitral regurgitation
Uh-huh.
and the atrial fibrillation.
Right.
But also recognize how they can affect each other,
Exactly.
especially when it comes to risk and management.
Couldn't have said it better myself.
So just to kind of sum up everything we've talked about today,
Okay.
we started with that initial exam,
Uh-huh.
how it can point to both AFib and MR.
Right?
We talked about the detailed investigations that happen next,
Okay.
with echocardiography being really important for MR, and looking at the cause and symptoms of AFib.
Right.
We talked about the two main ways to manage AFib,
Okay.
controlling the rate and trying to restore the rhythm,
Uh-huh.
and then the crucial role of anticoagulation,
Right.
using that CAGR-VAS score to help us decide.
Okay. And then we got into the different types of MR,
Yeah.
primary and secondary.
Right.
How echocardiography guides those decisions about surgery
Yeah.
and the importance of managing heart failure
Uh-huh.
in secondary MR
Right.
and how to think about bleeding risk when we're using anticoagulants.
Absolutely.
So we've covered a lot of ground.
We have, yeah.
but it's fascinating stuff.
It is. Very interesting case.
You know, when you think about how a structural problem like mitral regurgitation and an electrical problem like atrial fibrillation
Right.
can have such a big impact on each other,
Yeah.
it really makes you wonder what other seemingly unrelated medical conditions might actually be connected.
That's a great question. Right. And maybe we just haven't fully figured those connections out yet.
Yeah, there's so much we still don't know.
It's a reminder of how complex the body is
Absolutely.
and how everything is interconnected.
It really is.
So that's a good thought to leave our listeners with.
Yeah, I think so.
Thanks for diving deep with us today.
You're welcome. It's been a pleasure.
Until next time.
See you then.